Just connecting to the YouTube right now.
Folks, we've got a right to know script that's going to take a minute of just straight up reading.
So just connecting to the YouTube right now.
Yeah, it's good right now.
No script that's going to take a minute of just straight up reading.
So just connect.
It's showing for me that it's streaming on YouTube.
Okay, then I'll commence.
You're good.
Welcome to the first meeting of the Commission to Study Telehealth Services. I have a right to know script that I'll read, and then I think our first order of business should be just a brief introduction of all of the participants in this. I want to thank Alan Raff of the Senate staff who's convened us today, and Sonia Caldwell, who's in the background as well. So thank you both for assembling us today, and Tricia Malillo, my administrative aide for the time being, who is convened us. So the right to know script is to begin by, I am Senator Jay Kahn. Today, we are having the first meeting of the Commission to Study Telehealth Services. Before we get started, I will read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As the Senate member of the Commission to Study Telehealth Services, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order number 12, pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I'm confirming that, one, we are providing public access to the meeting by telephone, with additional access possible by video and other electronic means. We're utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform. And the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided in the General Court website. We've provided public notice of the necessary information for accessing the meeting in the Senate calendar. We're providing a mechanism for the public to alert the public body during the meeting if there are problems with access. And if anyone has a problem, please email. I'm going to read the email address. It is remote@ledge.state.nh.us, or you can call 603-271-3043. In the event the public is unable to access the meeting, will be adjourned and rescheduled. Please note that any votes taken during this meeting shall be done by roll call and by roll call vote. Finally, let's start the meeting by taking a roll call attendance, and when each member states their presence, please also state where they are and if anyone else is in the room with you during the meeting, which is required under the right to know law. So what I need to pull, oh yes, right, got it. And as we go through this, we might introduce ourselves, at least provide a title, an organization that you currently are representing here, both via an occupation, a volunteer role, or via a designee on someone's behalf. So I am Jay Kahn. I'm the sole state senator on the committee. I live in Keene. I'm in my home and by myself currently. And I'll just read down the list of members that was previously shared with you. Representative Bill Marsh.
Good afternoon, everyone. I'm Representative Bill Marsh. I'm currently at home alone in Brookfield, although my wife and two of my children are nearby and could conceivably walk in from time to time. As background, I serve on the Health and Human Services Committee. House Bill 1623 that set this up was originally my bill, although the Senate substantially rewrote it. I was pleased to have some input in doing that. I'm a retired physician as well as a trustee at Alliance Hospital. So thank you very much.
Representative Woods.
Good afternoon, everyone. I'm Representative Gary Woods, represent Merrimack 23 in Bow and Dunbarton. I also serve on Health and Human Services Committee with Representative Dr. Marsh. I've been involved with health in a variety of positions through the state as well as the AMA, and was involved about 18 years ago and became very close to establishing a pilot telemedicine program in New Hampshire. So I'm anxious to see how this goes forward.
Thank you, Gary. Is Dr. Ballard with us today?
Hi, Senator Khan. It's Jane Hipsch. I'm substituting today for this meeting for Dr. Jonathan Ballard. And just to introduce myself, I'm Jane Hipsch. I work for the Department of Health and Human Services and the Division of Medicaid Services. I'm currently the administrator for Medicaid's Medicaid Services Coverage and Benefits Unit. I'm a nurse by training. My area of expertise is children with special health care needs. I'm here today in Hudson at my son's house. He had some minor surgery this morning, so he's sleeping, so he won't be disturbing us. So thank you.
Thank you, Jane. And I think you'll be a valuable person to stand in for Dr. Ballard today. Thank you very much. Tyler Brannon.
Tyler Brannon. I am with the New Hampshire Insurance Department. I am the Commissioner's designee. I am the Director of Health Economics for the department, and I'm in my office in Concord, and I'm alone in the office, at least in my own office. Thank you.
Thank you, Tyler. Welcome. And you too will be very valuable for us during this initial meeting. Mary Lowry.
Hi, my name is Mary Laurie. I am the Administrative Director for the Dartmouth-Hitchcock Medical Center Connected Care Center for Telehealth, and I am representing the New Hampshire Hospital Association for this meeting.
Thank you, Mary, for joining us. Again, I think everybody here, I guess, has got something to contribute. All good. Joan Tulk.
Sorry for the delay to unmuting. My name is Joan Tulk. I work for Community Health Access Network as the Executive Director. I have a nursing, public health, and health information technology background, and I work right now with all of the community health centers across the state of New Hampshire, and I'm also representing Bi-State Primary Care Association.
Excellent. Thank you, Joan.
Thanks. And I'm actually indoors. My office is being renovated, so hence the snowy background instead.
It looks like my background. Kim Moen.
Hi, I'm Kim Mohan. I'm the Executive Director of the New Hampshire Nurse Practitioner Association. I am not a nurse practitioner. My background is actually in mental health counseling, and I spent some time about 10 years ago building a telepsychiatry network in northern New Hampshire, connecting the community mental health centers with the critical access hospitals, and also spent a couple of years directing the Northeast Telehealth Resource Center. So I'll be here representing the nurse practitioners, obviously, but hope I can contribute in other ways as well.
Well, thank you, Kim. Sounds like it. Rachel Chaddock.
Hi, good afternoon, everyone. My name's Rachel Chaddock, and I am in my home. right now, and I am alone in the home until my husband walks in, and then he'll probably walk through the room and disappear very quickly. I am the Vice President for Home and Community Services with the VNA of Manchester and Southern New Hampshire and Elliott Health System. My background is in nursing. I also hold a degree in health service administration, and I'm here as a representative for the Granite State Home Health Organization.
Well, thank you, Rachel. Where are you located?
My home is in Dunstable, Massachusetts.
Okay, thank you. And Scott Westover.
Good afternoon. I'm Scott Westover. I am the president of AmeriHealth Caritas New Hampshire, one of the managed care organizations operating here in New Hampshire. Today I'm representing managed care, and I'm in my home office alone in Hopkinton.
Thank you, Scott.
Thank you.
Sabrina Dunlap.
Hi, everyone. I'm Sabrina Dunlap. I'm Director of Government Relations at Anthem, and I'm here as the designee for AHIP and the carriers. And I am alone in my home office, also in Hopkinton.
Well, thank you. Well, Hopkins is well represented. It's good. And Patrick Ho.
Hello, my name is Patrick Ho. I'm a psychiatrist at Dartmouth Hitchcock, and I'm here representing the New Hampshire Psychiatric Society and the New Hampshire Medical Society. I'm the president of the New Hampshire Psychiatric Society and an executive council member with the New Hampshire Medical Society.
Thank you, Patrick.
I'm in my home office in Lebanon. My wife is in the house somewhere, but shouldn't be disturbing us.
Very good. And Ken Norton.
Hi, everybody. Ken Norton. I'm at my home office in Tilton. I'm the executive director of NAMI New Hampshire, the National Alliance on Mental Illness. I'm trained as a clinical social worker, but I believe my role on this committee is as a patient advocate. And I have a pretty extensive experience in community mental health, as well as dealing with family members with mental illness. And I'm also on the ethics committee of Concord Hospital.
Thank you, Ken. Good to see you. And there's another person, gentleman down at the bottom of my screen, Bill Ryder.
Yes, thank you, Senator. My name is Bill Ryder, and I'm the President and Chief Executive Officer of the Mental Health Center of Greater Manchester. And I'm connected in, sitting in my office here in Manchester alone. And I'm representing the New Hampshire Community Behavioral Health Association. And by way of background, the Mental Health Center has been using telemedicine since 2016. So we have a fair amount of experience in using it, and are doing now quite a bit since COVID-19 has hit. So I'm hoping that I can provide some insights from our perspective, and I'm very happy to be with you all and to learn some things from you all. So thank you very, very much.
Thank you, Bill. It's good to meet you, and I need some personal contact information from you. So if you could send me to my Senate address, phone number, and email contact, and that'd be great. Thank you.
Okay, will do. Thank you, Senator.
Thank you. So our first order of business is to elect people to lead this group. We need to elect a chair, a vice chair, and a clerk for the committee. So I see Representative Marsh. I recognize you.
Thank you, Senator. I would be pleased to nominate you to be chairman of this committee.
Thank you.
I would like to second that.
Thank you. Any other nominations? Thank you. We need to do this. Let me see if we can do these in with one roll call vote. Are there any further nominations for chair? Seeing none, we'll close those nominations and accept nominations for vice chair. And I would like to nominate Representative Marsh.
I'll now second that as well.
Thank you, Gary.
Thank you. Any other nominations for vice chair? Seeing none, we'll close the nominations for vice chair and ask for nominations or anybody who will volunteer to be clerk for the committee. It's not like we are on YouTube. Our minutes don't need to be like committee hearings in the Senate. Just need to have a record of our votes and presenters, key topics. But so I don't see it as that complicated. We should not expect that of anyone. So with that said, nominations for clerk or anybody willing to let themselves be nominated. Yes, Rachel.
I would be willing to volunteer as clerk if folks would agree to that, and no one else wants to.
Thank you very much. I'd be glad to put your name in nomination as clerk. Rachel.
And I will second that.
Thank you, Representative. Thank you, Rachel. Seeing no further nominations or offers, I will return to to our roll call, and we'll call the roll. We'll cast one vote for the Jay Kahn as chairman, Bill Marsh as vice chairman, and Rachel Chaddick as clerk for the committee. Representative Marsh?
I vote yes on the motion.
Thank you. Representative Woods?
I vote yes as well.
Jane Hipsch?
I vote yes as well.
Thank you. Tyler Brandon?
I vote yes. Thank you.
Thank you. Mary Laurie?
I vote yes.
Thank you, Mary. Joan Tulk?
I vote yes.
Kim Mohan? Kim Mohan?
I vote yes. I had to unmute. Sorry.
Thank you. Rachel Chaddick?
Sorry, I vote yes.
Thank you, Rachel. Scott Westover?
I vote yes.
Sabrina Dunlap?
Yes.
Patrick Ho?
I vote yes.
Ken Norton?
Yes.
And Bill Ryder?
Yes.
All right, thank you. We have a unanimous vote, and appreciate that. Thank you very much. The next order of business for us, and let's see, I need to try to share my screen. And let's see. How is that? Okay.
We can see it.
It's good.
What I want to concentrate on here, we can, if you had, want to There we go. So the commission's role, you've received this in an advance mailing, I hope, and if there's, we can attach this to the minutes as well, but this is the charge to the commission. Bill Marsh and I, together with Senator Sherman and Senator Bradley, were the authors of the final piece of legislation that included the creation of the Commission to Study Telehealth Services. And I appreciate folks who participated in helping write that telecommunications bill 528, House Bill 528 in the last session. Tyler Brannon, I appreciate you coming forward with that recommendation to create a commission, and the others who helped put some words to this. Just to review once again, the membership, I'll just scroll through that very slowly so that you can see how comprehensively we are constituted. And it sounds like we've got a good spread of people across the state as well. Our commission role, we should probably come back and hit each of these separately with some discussion about how we may wish to proceed with these relative to future meetings and more informed presentations. But clearly, the role of the Department of Insurance in informing this group with the data that might be collected over time. I think during the legislative process, we observed that we have quite an anomaly in this year with data, and that data lags over time. So we we'll come back to Tyler and further discussion about this item, just as to what the expectations might be and timeline for looking at utilization and cost information from the department. Second, the compilation of data from healthcare providers, and this will be valuable to hear from many of the healthcare providers that you represent relative to what data might be accessible, and again, the timeframes in which to look at both historic and future information. And then any other information that we can obtain, including that which we can get from managed care providers, how the information is being collected about various kinds of telehealth services for various types of healthcare delivery. So those are the three territories. I think they offer a great deal of breadth for us, and feel free to describe any other categories, subcategories that you feel ought to be become part of our charge. Just to continue, I should continue further to make note of what are the reporting requirements for the committee. We have no reporting requirement until December 1st of 2022. That interim report, it can be a summary of the meetings that we've held, testimony that we've received. It can also be an opportunity for us to make recommendations to a future legislature. So I think in crafting the commission, we don't need to wait until December 1st of 2022 to make recommendations about legislation that we believe would be valuable for furthering telehealth services in the state. So don't feel constrained by that date, but just to give you some sense of what an interim report might include would be suggestions about future legislation or information to be requested from different departments, which might lead to legislation. We could also recommend at any time that if this committee is not well enough constituted or representative sufficiently, any kind of membership change. And then finally, notwithstanding any continuation legislation, this committee will submit its final report in December of 2024. So if no questions about that, why don't we go back? I hope, hope folks have this well enough that we could go back to seeing each other on the screen and depart from this. I'm glad to bring it back or at least read it back if
Senator,
we need.
Can I add something?
Yes, I hear Bill.
Thank you. This is Representative Marsh again. One of the issues that I brought up when we were drafting this is that I do think that we need to pay attention to whether there are quality of care issues that may be brought up by the expansion of telemedicine, and in particular by the audio-only provision and the expansion of telemedicine in New Hampshire. Clearly, a doctor seeing a patient by telemedicine does not have the benefit of a physical exam in making diagnosis, and I think it should concern us, and we should ask the question, has this resulted in delay or misdiagnoses or other quality of care issues that may have come up? Now, how can we get data about that? I'm not entirely sure how we can get data about that, but I think it is an additional concern that this commission needs to pay attention to.
I think that'll fit in several places. So thank you for that observation. Okay, Alan, can we, let's see, if I go here, can we unshare my screen?
Yeah, you just have to go to screen share again and say stop sharing screen. I can do it for you too, if you want me to.
Little confused about how to do that because I'm looking at the document and not the screen apparently.
I gotcha.
Okay, so back on number one, maybe, yes, Rachel.
I was just going to mention too, in looking at that information that we'll be talking about and collecting, one thing we might want to consider is the impact of COVID on all of this, because we're going to see changes in utilization of this, and also how that has impacted the ability to have access in a time when resources are much tighter, and in some ways it can be more difficult to get appointments and things like that with the risk to patients. So I somehow COVID, I think, factors into this perhaps.
I think absolutely it does. And any other broad comments? Because I think relative to the first charge and the available data from the Department of Insurance, I think Tyler, you probably have some perspectives both on the point that Rachel just made and then relative to the charge as well. No further comments. Tyler, would you like to take on that first charge to the committee and Rachel's point?
Sure. So I'll mention just a couple of things. I think most people are aware that New Hampshire has access to what we refer to as our New Hampshire Comprehensive Health Information System. What that is a raw claims database. And we collect claims data. It actually comes in monthly, but we create quarterly extracts from the different carriers, and it's fairly complete for fully insured business, a little less so for self-funded. The good news is it's like a very large sample of claims data that we have within the commercial market in New Hampshire. It is raw claims data. So the good news is you can look at a very high level of detail. In other words, you can look at a particular patient, a particular day, a particular diagnosis, particular types of services, a particular provider. It is all anonymous, so you can't tell who anybody is in the data, but you could track somebody over time. So to the extent you could see if somebody was receiving services historically in person, or at least it being billed that way in person, and then you could see a change in how that person is receiving services through telemedicine. The good and the bad news is it's a great bird's eye view of what's going on. And the bad news is that if you're really trying to answer a specific question, you need to be quite deliberate in trying to answer that question. It's very easy to get distracted and do what could be considered more of an academic kind of research, and you start to chase certain questions and you look at a very big picture, but at the end of the day, you don't really have actionable information. So I think to the extent we're trying to answer some specific questions, particularly around cost and utilization, you probably can't imagine a much better, richer data source than our claims data. That being said, it might be worth kind of hearing from the provider community about more specific examples that they're experiencing before you try to answer all the questions at once or tackle the whole question with one analysis and report. It would be a way of kind of looking for patterns across the system, and particularly if you've got kind of policy approaches or possibilities for recommendations for legislation going forward. Clearly, the bill that created this commission had a number of new requirements, and it's a little bit hard to predict how those new requirements are going to play out over time. But again, that claims database is a really rich resource. There are always limitations with the data. Hopefully, the telemedicine services are largely being billed correctly, using the right modifiers, the place of service, things like that, that I'm sure the folks in our billing community understand really well. The good news is the carriers all were very responsive when the executive order went into place, and getting the technical changes in place happened perhaps in record time. So I think any work we do could be very interesting. Historically, when we've looked at services provided through telemedicine using the claims data, it's been very, very small. And most of it has been within the mental health community. But that being said, I think to some of the points made earlier, going through COVID has really accelerated the use of telemedicine services. And we are certainly going to have a much richer database as we look at the cost and use of these services going forward.
I recall in conversations 6 months ago that you said there is a lag in the claims database, that some of the spikes in use that we could expect from March to the present during the pandemic would not show up in data until sometime after the experienced claim. So can you just give us some context around the temporal problems that there are with looking at the data? Yeah, it is certainly like driving with a rearview mirror. We assume that you're going to be using data that are at least 6 months old. And remember, there's a certain amount of time after the service takes place before it gets billed to the insurance carrier, gets processed by the carrier, gets put into their database, and then gets submitted to the state, and then gets consolidated. So if, typically you look at a year's worth of data to try and understand patterns or potentially even trends, you're using multiple years. We might be able to look at, for example, a quarter's worth of data, but you're still going to be running. I mean, if we were to do the analysis even today, you're really going to be looking at data that's going to be pre-pandemic. So but in the near future, we should be able to look at least a quarter of data that could be robust. And over time, particularly as we approach we probably don't want to wait to the 2022 date, but by then we would have a very rich set of data telling us what did happen beginning in March this year, and then you'd be able to compare that to prior timeframes
as well as what takes place, going into the future. So there is always a lag, and that is certainly something to be aware of, and particularly to the extent you're looking for patterns over time.
Is there a report that you look at, that the department looks at, or that you share with perhaps other public bodies that at least could give us the frame of what the quarterly summaries look like?
No, I occasionally have to remind people we're not any kind of a reporting shop, so we don't produce reports regularly. The closest thing we do to producing reports regularly is updating our health cost website. But we do produce information on an annual basis that's a part of our hearing and annual report on premiums and cost drivers. That being said, that is intended to characterize what's going on in the market overall and looking at particular trends. Certainly in the future, telemedicine would be appropriate on that front. But I think anything that would be answering questions this commission would have would be a kind of a special analysis. The department does have a consultant under contract to do those kinds of analyses, but we'd want to be, quite prescriptive about what we're looking for, and obviously recognize there's a certain cost in performing the work. You don't want to end up with 3 or 4 different analyses or reports, all focused on basically the same subject.
Would it be valuable, useful for the committee to be informed by your consultant of standard reports that might be useful? Maybe the person has bi-state, multi-state experience. Anyway.
I think our contractor would be looking for direction more so from the insurance department and the commission before performing work. I don't think that they'd have a lot to offer in terms of comparative work, or they're clearly experts in using claims data, but I think everybody's sort of focus on telemedicine these days is going to be relatively new. So I'm not sure that they might be able to answer questions, specifics around the detail of the data. That being said, I've got a fair amount of experience working with the claims data myself, and could probably answer those kinds of questions as we think about the type of analysis and report we might be looking for.
Okay. There's thoughts about the kind of data that claims data that you either have experience using, viewing in your own sectors?
I would say that it's worth kind of identifying the services that are potentially of greatest interest. In other words, are we most interested in services that fall under that kind of mental health umbrella? Are we more interested in kind of getting just a snapshot of the landscape? And how do we want to kind of create a methodology so that it's a productive analysis, something that starts to answer questions? Some of the obvious questions are, what kind of access improvements have been out there? But likewise, what are some of the associated costs? What's perhaps the distribution between audio-only visits and some of the other types of services for telemedicine? That being said, I know the carriers have been watching these trends very carefully. The insurance department has been in touch with them, at least our major carriers, every couple of weeks. So rather than waiting for a kind of an analysis by the department, you might be able to get some preliminary information just by asking those kinds of questions of the carriers, at least to the extent that they're high-level questions that they're probably tracking anyway.
Yep. Well, certainly we'll ask Sabrina to offer a thought there too, and Jane, what kind of information there might be from Medicaid as well. But Sabrina, you got some experience in these?
Well, like Tyler mentioned, we look at claims data and tell them about certain trends we're seeing. So I'm certainly not the person drilling down on the data, but I can look for things like trends and report out on, some of the things we're seeing. And, you know, we can, if people are interested in certain segments or like the types of telehealth people are using, like audio versus video, I think we could drill down on some of that.
I think that is of interest. And of course, we're going to need to hear from care providers what they perceive as the difference between the two. And it comes back to Representative Marsh's question about quality of care.
A related question that has to do with the claims would be whether a telemedicine visit is able to satisfy a patient's needs, or is it going to be followed subsequently by an in-person visit in very short order? And I would think that an examination of the claims database could tell us on, and we probably need to break it down by specialties, because I'm sure it'd be different for somebody who's coming down with pneumonia than it is for a mental health visit. But we could have some percentage of the visits, you know, are whether or not they're followed up by some other visit, particularly an in-person visit within a week or something like that. Because if we're paying for these telehealth visits and they accomplish the need, that's one thing. But if we're paying for them and they don't, then that's something else.
Good perception. Representative Woods?
Yeah, I'm sort of asking the question from a different direction, and that is the idea of cost benefit. Are the databases that we have access to right now sufficiently robust that we can make a determination that, in fact, like Dr. Marsh was saying, you know, a patient gets a telehealth service, is that a true cost benefit? Not just that they get a service redundancy, but is there a true cost benefit? Are the databases available to do that? If not, what do we have to add to get that cost benefit? Because from my perspective, the COVID situation has precipitated a movement which has been long underway. And just nudged it along. So I think we'll, just as a sidebar, my understanding is that telemedicine got started in our location nearby Boston. So the story goes, the medical director for Logan Airport was tired of having to drive through the tunnel to check out a cardiac patient who was ready for an air flight. So I said, why can't you just send me their EKG over the telephone somehow? And that's my understanding is the first element of telehealth.
Save that air flight.
Getting back to the question, I don't know if Tyler can answer that, but or Sabrina or anybody else that has access to these databases, are they sufficiently robust, or do they have to be expanded in a way to make a true cost-benefit analysis?
So I'll comment first. I think the trick is going to be less about the data and more about the methodology that is used to make a decision. I think the good news is that these are the kinds of questions that are relevant in a lot of other states and a lot of other environments. I mean, everybody wants to look at the cost benefit of use of telemedicine services. And it really is kind of an academic approach, whether or not you're looking for statistically different changes over time. And then at some level, perhaps replicating that kind of analysis in New Hampshire. But I think this isn't going to be really straightforward. I think the example Representative Marsh gave about what about people who are going in for in-person visits shortly after, that kind of analysis could be done. But could you say there's sort of a conclusive problem one way or another, or conclusive benefit? And I think that's where developing the methodology, you've got to be very careful. So I think the limitation will be less on the data side, perhaps more in the methodology. I mean, you've got diagnosis, you've got data service, you've got the procedures being performed, you can track the same person. So there may be additional information that would be helpful. But But again, that's kind of part of the methodology and putting together a good study that's really going to give you findings that are going to be conclusive.
Maybe if I could add, I guess my point being, taking the example that Dr. Marsh brought up, a patient has a telehealth conference and then shows up in the office a week later. Maybe the telehealth exposure precipitated that and said, yeah, I think you do need to come in. So in that sense, it's measured as a redundancy. And so that's a negative, so to speak. Nevertheless, patient calls, gets a telehealth conference. No, that's a standard sort of thing. No, you don't bother coming in. And so that saved one. And so that's why my comment was, or my question was, the data is going to have to be sufficient, or I guess your comment is the methodology is going to be the aspect that needs to be sufficiently robust, is what I'm understanding.
Yeah, you'd have to be able to say with a fair amount of certainty that if this is happening, it means this, and that's going to be the trick. And I mean, there may be folks that have specific expertise within a particular type of service or certain types of treatment, and hopefully that could be generalizable across to others. But and I'm sort of thinking, I mean, the use of telemedicine services in the mental health side of things has been so high. Perhaps there are clearer indicators within that context. That being said, you know, primary care or even oncology, perhaps a number of other ways of looking at this. And I think that is as much a kind of a clinical question as it is a data analysis type question.
Okay. Jane, curious what data might be derived from Medicaid reporting?
Yeah, I think, you know, relative to the, you know, Medicaid data, one of the things that we've been wanting to look at is, you know, given the advent of COVID, who are the provider types that have billed for those kinds of services, you know, physician services, federally qualified health centers, community mental health centers, to kind of look at, you know, the uptick of telehealth activities within the provider type, and also to look at the utilization of services for telehealth. What are the procedure codes that are being billed in terms of, you know, their short descriptions, so that we can get a better handle on, are there specific kinds of providers that are billing only very specific kinds of services, and, you know, utilization by, you know, our members, how many members are, you know, taking advantage of telehealth as an option. I think relative to, Representative Woods, your comment relative to costs, I think that's been a hard one for at least in the Medicaid space, because we've looked at, you know, telemedicine will save costs in terms of transportation, so that the members aren't traveling to see specialists. We've tried to look at childcare costs, so less childcare, less time off from work, you know, those sorts of things, but those are all soft costs, and we don't have a robust database to look at it. And we've had very limited data on satisfaction with telehealth services. I think we've been pretty dependent upon providers if they are doing satisfaction surveys with their patients around, you know, was it, you know, did you like the telehealth you know, service, did it meet your needs, any other kinds of things. So that's what I think that we have, that we're going to be able to, you know, produce for data. But I think we're going to have the same issue that you have, Tyler, with claims lag. And, you know, when's the best time to start putting together the reports? Do we wait 6 months for claims lag, or do we wait longer? So I think those are the things. But I think we have the database at least to look at who are the providers and what's the utilization and what are the procedure codes and the services that are being delivered via telehealth.
Just to give you, if you're not looking at the bottom of your Zoom, we've got 42 participants in the conference. Clearly, we're just 16 here. And so there are questions that folks might have. We'll check our time at the end here to see if we want to open that for questions. I did get one, Jane, and it had to do with the access to telecommunications services. And so are there some general demographic statistics that we might look at that show that certain parts of our state are disadvantaged in the access? I guess on one side, if you can't do it through video, the advantage of both the executive order and the legislation is that it left the audio capabilities. So it should be unlikely that people had no access to telehealth services. But I suppose if there is evidence about the differences, maybe we could see that by different kinds of services that were accessed.
Right. And I know that in past years, the Department of Economic Resources had a telemedicine subcommittee at one point in time, and they were putting together maps of New Hampshire with that kind of information around broadband access, so that they might be a resource to the committee to be able to bring forward that data. I know they've gone through some reorganization, but I know that they had that a couple of years ago.
That's the governor's office of strategic initiatives.
I believe so. Yep.
It may be important too, when we're looking at the availability of broadband, is to also consider the fact that that can be a barrier for providers as well as the patients receiving the care. Especially, we saw that a lot up in the North Country as we were having on-call clinicians, for example, that might be in Gorham, who, it's going to be midnight and they're going to get a call. Do they have the connectivity in their home to be able to even be to provide the services as well?
Bill?
Yeah, I would like to ask the Hospital Association for data too, and not just the claims database. I know our hospital, we had to reorganize staffing because of the increased demand for telehealth in the springtime, and then that leveled off or declined a good bit in the summertime. It may be going back up now. I'm not as privy to current data as I was when I was still practicing. But I think it would be a good idea for us to ask Mary to see if the Hospital Association has insights that they might want to share.
Yes, absolutely. Apologies for having a non-functional camera, so I can't raise my hand or wave. But the New Hampshire Hospital Association has been in the process of developing a survey to collect information from the providers and the hospitals. And certainly the big hunks of information in that space are around utilization. Patient experience is another big factor. And I think I just wanted to reinforce one of the ways that we've certainly thought about this, the audio only perspective, is what was just mentioned, that it's been recently not necessarily an alternative to in-person care or video care, but the alternative to no care at all. And that's something that we take very seriously. And I think just two other things, as we think about the optimization of telemedicine in our health system, specifically post-emergency, we are really working on making sure that we are targeting the modality with the care, right? Understanding what kind of service or what kind of care delivery service makes the most sense for this particular kind of care. And that way we could best match, for example, those audio-only services with things that are clinically appropriate for it.
Yes.
Thank you. A follow-up, Mr. Chairman.
Yeah, sure.
Yeah, I think that this survey from the Hospital Association may very well give us a way of getting into some of those quality of care issues, because the hospitals are obviously very concerned about the patient experience and the quality of care that's being delivered. So I'm hopeful that that survey will give us some insights and help us to answer some of those questions.
What do you think, Mary?
Yes, absolutely.
So are they assessing patient experience?
It's still something that's in development, but we have an opportunity to make sure that we are targeting that. I think one of the other pieces, the flip side of the patient experience, is also the provider experience as an important component in thinking about the future of telemedicine delivery. And I think one of the things that's really hard is that we have had this huge expansion because of COVID, and thinking about the comparative time periods and also bearing in mind the lag for some of the data, it doesn't really feel like it's going to be that helpful necessarily to look at what happened March through April, May, June, and then compare it to pre-pandemic, because the volume of telemedicine was so small in the state then. And so I'm glad that there's a relatively long time frame for this commission to develop a report so that we can have time to analyze perhaps March, April, May, June to the same time frame in 2021, for example.
Yes, understood. Bill Ryder, and then Joan, and then Rachel.
Thank you, Senator. The Mental Health Center of Greater Manchester participated in a multi-state, multi-site research study through the Vanguard Group on telemedicine just this year. And we have some preliminary data from that. And I'd like to ask, how can I get that to the members of the committee? What's the methodology?
Sure. If you think that there's something written up that's easily digestible, we can circulate that through our Senate staff between meetings. So that's one of the advantages of legislative support to this, and besides the calendarization of our events. I'm sorry I didn't hit that before, but you're giving me that opportunity, Bill. So we can do that. The other is, we can probably schedule another meeting in January, meaning that the legislative session is going to take off slowly and then hit accelerator really heavy come later in January and through the spring. So it's a little harder to convene, but not impossible. So if we think of maybe monthly meetings, I think the next meeting would be really valuable to have some of the folks that have been trying to analyze use and satisfaction. I think that would be a good, let's hear who those presenters might be, so that between meetings, Bill and I can be making those contacts and arranging. All right, let's see, Joan, you had a comment?
Just a brief comment. As far as looking at the data, I think that we should be careful looking at the data that we get from that spike in March, April, June, because a lot of the healthcare providers were really scrambling to get telehealth up and running during that time. So there was probably not the best provider or patient satisfaction as they were trying to get people hooked up and have enough bandwidth to do that. So I think we'll see, as time goes on, probably more accurate information. Also, even just learning how to code and bill for the telehealth services, there was some ramp up time on that as well. So I'm not sure that we want to put a lot of faith behind the data that we get for like March, April, May activity.
Thank you, Joan. I'd like to come back to that question about coding, and there's still some opportunity to introduce some legislation, at least on the Senate side, and clearly through our representatives here, through House hearings and amendments. So if there is some data refinement that folks think is not just administrative, but perhaps legislatively would be helpful to create an environment for greater detailed collection. I'd like to just return to that topic before we wrap up. Rachel?
I just needed some clarification. So when we're looking at this study commission, are we considering all individuals who receive telehealth services, regardless of if they're commercial or Medicaid? I'm thinking about the Medicare population. Are they included in this group?
Certainly, it's a healthcare health insurer.
So
a lot of data there. Jane, you're going to have to respond, but I assume much of the data that is received in Medicaid is defined through Medicare. So I assume there's quite an overlap.
Yeah, and I would think that, you know, Medicare should be considered as well, because they, as part of the COVID or the public health emergency, did expand telehealth services. So I think they should be looked at.
So a concern from a home care perspective is, unlike all the other providers, we are not able to bill Medicare for telehealth services. So I think we would need to solicit any information that the commission needs from our membership.
Mm-hmm.
If I can comment just on kind of the focus, and as we talk about Medicare, that's a good example of, I'm not sure how much it is worth focusing on that if our purpose is really to think about what we can do at the state level. In other words, if we're looking at the commercial insurance changes, if we're looking at changes that relate to Medicaid, Medicare is a federal program. Even Medicare Advantage is regulated by the federal government. There's not a lot we can do to solve problems. So I think to the extent that we're deliberate about the questions we're asking, because the answer to those questions is going to inform the New Hampshire legislature, then I think we want to make sure we're kind of deliberate in doing that.
Thanks, Tyler.
I don't
It's
know.
understood that legislatively there's not a lot we can do with the Medicare program. The in-home care market is that is clearly an alternative for communications between healthcare professionals and the kind of support that might be valuable for telehealth services. I don't want to overplay this one, but I understand where Rachel's comment. We're going to need to, if there's no data available through, but you're billing other insurers, Rachel, right?
We have the ability to bill some other insurers, but I would say the vast majority of everyone's billing is Medicare.
Yeah.
In my industry.
Perhaps Tyler can correct me if I'm wrong, but I think that the Medicare supplemental policies would be reflected in the claims database. And so therefore we would have data on that, even if we can't affect Medicare legislatively very much.
So that's an interesting question. So until recently, as in a few months ago, our rules did not include the MedSup. That being said, MedSup is regulated at the state level. The reality is there's very little we can do with it at the state level because of all the federal rules. We were getting some of those MedSup submissions anyway. So even though it wasn't required, the data were coming in and hopefully flagged as appropriately as MedSup. It would be difficult, I think, to use because you don't have the rest of the claim, but it's just not something we've done any research on. It could be more insightful, particularly by the time we're doing reports for this commission than we've used it for in the past. So it'd be interesting to kind of explore that. And I think to the extent, just to add to my earlier comments, I think if we're identifying problems, systemic problems that are related to Medicare policies, then then that may lend some insight about what we can or can't do at the state level, just because Medicare is often the elephant in the room for providers. I mean, you're not going to set things up for payers that are going to be radically different, knowing that Medicare has got certain policies and procedures in place just because of the amount of volume of patients and revenues that come through the Medicare side of things. But anyway, just a couple of thoughts.
I think this discussion is pointing out that one of our tasks initially is going to be starting to build a definitions table. And I think our conversation today about what is the claim data universe, how are we defining it, maybe one of those initial definitions that would be good for us. What do you, any thoughts about that? I mean, we know we've got group plans, self-funded plans, Medicaid plans, relative to the provider universe. We've got, I'm sorry, relative to the insurer universe, we've got provider universe that maybe we could categorize like the New Hampshire Hospital Association. And again, I'm so that we know what we're talking about when we talk about each of these groups.
I would not want to limit that at this point in time, Senator, for this reason. I mean, you might think that we could limit it, for instance, by excluding Medicare, because we can't do a lot about Medicare. But one of the things about the Medicare program is it doesn't allow billing for services that are not allowed at a state level. And we expanded services that were permitted to be done with the telemedicine bill. And so therefore it's quite likely that more of those services are getting billed to Medicare, even though we have no control over the reimbursement and the claims. So I think it'd be premature to exclude that portion at this point in time.
And I'm not disagreeing with you. I just, and maybe in the claims definition, we do include Medicare. I just think we ought to be clear for, as a group, what is the claims universe. And maybe there is a little spreadsheet that goes with that to say that we can influence what information we can gather, what information we can't.
I think it's an important piece to the entire picture. If we think about reporting out on utilization and adoption of telemedicine, if we don't, and I think it's got to be part of the story that we might see an area, for example, home health, where adoption might look low or utilization might look low, but that might really be a product of the reimbursement and not a product of a desire or a will or applicability of the use of telemedicine in that way.
Yeah, I think if I could comment, just I think that the focus of the commission, I made certain assumptions that a lot of it was going to be on commercial insurance because of the concerns around costs when the legislation passed. I know there were similar concerns about Medicaid coverage, but I think to the extent that we identify what's going to be most important to focus on going forward, whether or not there are going to be barriers on the provider side, whether or not it is commercial coverage or something related to Medicaid, that'll be helpful in sort of informing the discussions. And we do have enough time that we can certainly consider a number of different aspects. But I think to the extent that we're kind of thinking about, as you refer to, kind of the claims and where they're ending up or certain types of coverage, that is an important part of the process and the question about where the priorities of the commission should be.
So if we have, if we define the universe you're suggesting, then there could be subsets within the universe that have different intensities of review because of the availability of data and the concern for public policy.
Yes.
Anybody else? I think we appreciate that, Mary, you said the New Hampshire Hospital Association is gathering some information. And is there, I guess I wanted to ask if there are any national efforts that folks are aware of, or other states perhaps that had a working group like this on telehealth services that we're aware of that we can learn from others?
This is Mary. I would just say that there are various industry efforts to look at that information as well. And you shared the link with us earlier today from the AMA. So there is similar information out there by various constituencies that might be helpful from a context perspective.
Yeah. Are we aware of any of those? Are you, anybody else aware of any of the national efforts? I appreciate that Bill still's active with his AMA membership, and that'll be a good source. Bill?
I'm not a member any longer, but I keep getting the non-member emails because they want me to pay dues again. But I think it might be worth, and you probably are the best one to do this, contacting Senator Shaheen's office, because I think that she has an effort underway to make some of the temporary changes that were made to telehealth by CMS permanent, and so they may have some relevant information.
And she does have a healthcare staffer that maybe that person might join us at a subsequent meeting.
Mm-hmm.
Good idea. Yeah, Joan?
We may want to bring in the Northeast Telehealth Resource Center to help guide us collecting some of this other information, because this is like all they do. And they also are connected with the National Telehealth Resource Center. So they might be able to help us with information. Also, from the Community Health Center perspective, the Health Resources and Services Administration Bureau of Primary Health Care, gets reporting from the FQHCs on their patients' activity, including, they're adding some questions about telehealth to their data collection. And they also collect data on quality measures as well on the FQHC. So there may be some good information that we could get from them, for primary care. I also like to, I hear a lot of discussion about the cost or cost benefit of the care. And I hope that we are also going to talk about access to care and how telehealth might be actually improving access to care to folks that may not be getting care at all because of where they live or what they can afford, that we should take into account as well.
Yeah, Bill.
Yes. I don't mean to interrupt you. You can go first.
No, I was going to invite Ken and Bill maybe to offer some thoughts relative to people who
relative to access to care. It's even bigger than that. We've discussed this at my Rare Disease Advisory Council, because telemedicine gives rare disease patients access to specialists which we may not even have in the state.
Right.
And so it's not just an affordability and transportation issue, but it may just be an availability of specialists in our even in New England, actually. So that's actually a huge issue and something I'd very much like us to consider.
So, Bill, it kind of resonates that somebody from your territory of the state or north even, but that part of the state might wish to give us some insights to specialty care access that suddenly that they're trying to evolve for patients.
I think that the best source for something more comprehensive would be to ask the Hospital Association again, because all of the critical access hospitals don't have specialists that they need. And my critical access hospital, as well as the other 12, have all utilized telemedicine to expand our availability of specialty physicians. So I would defer to them because they can get us far more comprehensive insights.
Mary, would you like to pursue that thought?
Absolutely. Yes, I'd be happy to.
Yeah, with some of your colleagues then, and see if there is a logical a source for having coalesced some of that perspective that might be provided to us.
Could the Behavioral Health Association also be tapped for that to see how access is being improved through the for mental health services to specialists? For example, I know in the North Country, access to psychiatry care, especially child psychiatry, was greatly increased by telemedicine. So, and I don't know if that would get captured in just looking at the hospitals.
That's
a good point.
Why I was hoping Bill or Ken, with your behavioral health perspectives, if you what sources of information do you suppose might be available to give us insights?
This is Ken, and NAMI isn't really a service provider per se. We are doing some telehealth peer support efforts, but we're not providing clinical mental health services. So I would think that Bill or the Community Behavioral Health Association would have a lot better handle on that than we do.
Yeah. Bill, any thoughts?
Yeah, I think that we may be able to bring in some additional data other than this study that we were participating in. I know that they did a bit of a study at Greater Nashua Mental Health. And then just, kind of tying back to comments that were said a few minutes ago regarding Medicare. We have the mental health area, we have a community mental health area, we have a big cohort of patients who have are duly insured by Medicaid and Medicare. And there is under normal circumstances, there is the geographic exclusion of urban areas for Medicare patients to use telemedicine. And that exclusion was decoupled by legislation here in the state for Medicaid, but it creates headaches for those who have the dual insurance. So there are some complications, and I agree. I think there's a lot of I think Dr. Marsh said this, there's a lot of interest from our federal congressional delegation and our senators to see that telemedicine is, brought into the 21st century and creates or takes down what Joan was talking about, and that is the access to treatment. And I do feel that we've seen significant drops in our rate of patients not showing for treatment. And that means that we get an affirmative connection with them and help them stay on their treatment plan, help them to stay remoralized and encouraged. And we see that as a good thing, and we see that as a good utilization of the resources that we've committed for behavioral health. So, and I do think that that we were able, because of the pivot to telemedicine in the height of the pandemic, right at the very beginning, to be able to stay online with a whole cohort of people who have, some serious chronic illnesses, and I do think that connectivity proved to be life-saving for many. So, yeah, I'll work with our association members to bring forward as much information and as much input as possible to the discussion.
Yeah, I think that, you know, two thoughts on this. One is in this early meeting of this group, we should do a couple things. One, we should tackle what are the questions that we're trying to answer. I think we can all have a homework assignment before the next meeting, and I could take the input that each of you would provide and assemble what are those questions that you believe that this commission should attempt to answer. A second thing that we could tee up is what are the virtues? What do we believe through our own experiences or what's been conveyed to us? What do we believe are the advantages of telemedicine or telehealth? And just so that we catalog what those are and not lose sight as we start to tear into this, that there are benefits to this, and what we're trying to do is find evidence that in fact are what we believe is in fact true. And anyway, I think both the seeking what problems or what questions we want to answer and what virtues we want to preserve are a couple of things that we could easily do as we launch.
Is there also a piece in there to think about the questions that have already been answered, sort of through national research or experience, that maybe don't need to be revisited in our work? That we could just sort of say, you know, patient satisfaction has been addressed to blank extent. You know, because I worry that this mountain is so big, and some of the work has been done. So we start at a spot.
Yep. Good point, Kim. Good point, and we shouldn't lose sight of that. It shouldn't stop us from identifying what the questions are, but definitely if we can identify sources of that information, we should.
I was asked to speak on telemedicine at the recent annual meeting of the National Organization for Rare Diseases. And this is actually one of the things they are pushing for this year, as they want to have other states expand telemedicine, as we have done in New Hampshire, really quite extensively as one of their big pushes for the year. And what impressed me most from this meeting was we are really on the forefront here in New Hampshire. We've implemented things that other states have not done. So I think there are an awful lot of questions for which there aren't answers yet. And I believe patient satisfaction, particularly in the sense of, did it actually address my problem? Certainly the access question, they're satisfied by that, but did it actually address my medical problem is not quite the same question. There are questions out there. And so we're just going to have to do the work. Fortunately, we got years to get this done.
Yeah. But Tyler, it will be helpful, and Jane, it'll be helpful if you knew what the questions were that we were trying to answer, so that that development of information could begin sooner, right?
Mm-hmm. Yes.
Gary?
Yeah, I think we're aimed in the right direction of thinking and painting in broad brushes, looking at broad concepts and large benefits and, so forth. But at the same token, as we go forward, I think we should also ask ourselves the question, are there niche areas that we would think might be of benefit? And I'll give you a couple of examples. As I mentioned, I was involved with a group about 18 years ago that tried to set up a telehealth program. We came that close. An example is Texas with a fellow by the name, I don't think he still does it now, Steve Villegas. He was a hand surgeon. I'm a hand surgeon myself. He ran the prison program, 400 facilities, totally on telemedicine through Baylor, and had a system where visits were done so that the inmates didn't have to leave the prison. So they saved people who are trying to get out, sometimes with self-inflicted injuries just to get out for the day. The guards that had to do the transport, there was a huge savings. Now, we're not Texas and we don't have 400 prison facilities, but that's an example of a niche kind of program that was extraordinarily beneficial. Montefiore Hospital set up one in New York City. Again, this is a number of years ago, for the homeless kids. And they had bus stations, they called them. And the bus would arrive at certain areas, and the homeless kids knew where they would arrive. And if they were on antibiotics, they could see it at this location, but if they were someplace else next week, they could go to that bus stop and get the bus, and their records would be available, and they could get their health care in continuity, even though that they were migrating around the city. So 2 examples of niche kinds of use of telemedicine. Not that that has to be where we look first, but as in the long term, something for us as we go along, that something like that might crop up.
I hear you. You started by saying, don't let the broad strokes obscure the niche areas that we can observe, and maybe they can be replicated by other niches that through example, right? That's good. All right. We've almost gone 90 minutes. That's usually a peak time unless we do some wrap up. Any thoughts that folks have that maybe Scott, if you don't mind me just drawing you in,
Sure.
But, any thoughts that you've got before we close up?
I have a page of thoughts here. A couple of them are that, as we've talked about the availability of data, I think the managed care organizations can bring insight to about 204,000 Medicaid beneficiaries in the state. And one area that we have watched very, very closely as part of the state of emergency response, Dane will know about this, is health. And I think what we will be able to do is add to some of the data that Tyler was discussing, and between multiple data sets, perhaps draw some directional conclusions. So I'm excited for that. And the other is to touch base with my managed care organization colleagues, where we are at least Centene and AmeriHealth Caritas operating in multiple states. And in the Medicaid space, there's a very extreme focus on looking at safety net providers and the application of telemedicine in those environments. And we can look at what's happening in other markets and bring that back to New Hampshire. I think that may be one of the niche areas that Representative Woods was speaking to. Some of the safety net providers have not only embraced telehealth, they've used it, frankly, to save their practices. And I think that that's worth looking at. Just a couple of thoughts there, Senator. Very good meeting. Thank you.
Thank you. Others had good participation. Patrick, any thoughts you want to leave us with?
No, I don't think anything additionally. I think it's just really great that we're trying to define the scope of our commission here. And I think as far as mental health care is concerned, then it's really important to look at the access issue, as has been brought up before, but then also thinking a little bit about the mental health outcomes and I guess what the state has been able to do with the advent of increased telehealth care, as far as potentially maybe keeping down the IAQ or keeping the EDs a little bit more more free, I guess, and what telehealth's role has been in all of that. But I think looking at outcomes and looking at access is really a big key component of what we can do in this commission.
Yeah, that's one of those data intersections that would be valuable to understand. The emergency departments loads perhaps being eased some by telehealth consults that psychiatry, psychologists, social work have been able to utilize. We've got a couple of tasks that I think I can, with Rachel's help, I can get back to folks with. Bill, we can probably come up with some assignments between meetings relative to our thought process on the problem. And if there are speakers that folks would like to identify, as Mary perhaps offered with the Hospital Association, being able to provide some insights to the critical access hospital usage, and maybe add this question that Patrick offered about emergency room usage. And Bill Ryder, maybe there's there is some community health, mental health care statistics about lag times between visits being shortened because of, but anyway, what are the data points that the community healthcare providers are trying to assess relative to telehealth care in this space? And Tyler, I just I welcome your leadership on data questions. I think you folks are probably have that experience, as you were saying, in the economics of healthcare. If there are folks to make that presentation, and Sabrina, I suspect your folks are also looking at the same kind of universe of healthcare economics, that there are any broad strokes, broad vision that we should have to help inform our problem identification questions, that would be welcome to hear who you'd like to invite to a future meeting. Okay, well, with those thoughts, anything else? Closing? Jane? Yeah, Joan?
I just want, maybe we'll do this in our homework, but what questions we want to answer, I just want to make sure that we're really clear on the definition of telehealth. I'm wondering if it includes remote patient monitoring. And I think that, some like the FQHCs, I don't believe are reimbursed for remote patient monitoring. So we wouldn't be able to get the data out of the claims data about what's going on there. So be happy to do some other kind of supplemental data on what's going on in that arena as well.
And Joan, you had mentioned some sources of information previously that maybe you could forward those as well. But I would say, relative to remote health, remote monitoring, it is part of the statute, both for commercial and Medicaid providing.
Yeah. So yeah, we should be able to provide some data for for about 120,000 patients, people in the state of New Hampshire that are served by the FQHCs. So that may be helpful to inform the commission as well.
Okay.
Thank you.
And you say no, thank you. FQHCs will. And Jane, you want to do some mining and of Medicaid data?
Yeah, I'll get in touch with Andrew Chasma in our data analytics unit and see what he can do in terms of, putting things together. And I think, Tyler, I may ask Andrew to reach out to you so that we can coordinate the data queries.
Yeah, no, that sounds good. In fact, Andrew would have the same access to the commercial data. So to the extent the logic is set up to look at the Medicare data, it'd be pretty easy just to apply it to the commercial things as well.
Yep. Okay. Thank you.
Okay. Next meeting. Again, I think we should be fairly flexible going into January. Any suggestions about the
Hey,
5th?
Senator, just to give guidance on scheduling, the new majority has stated that they want to actually only have the commission meetings taking place on Monday and Fridays to allow for the actual committee meetings. So keep that in mind. That would be the Fridays are the 8th, 15th, 22nd, and 29th. And the Mondays are...
Yeah, I got the calendar up. Yeah, looking. Yeah, so I think at this point, we could have some homework assignments, collect some information, assemble it between now and the next meeting. I'd suggest that we probably aim for the 11th. See if we can get our oar in the water quickly. How's that feel for folks? And it's a Monday. Just maybe people have morning meetings on Mondays. That an afternoon on Monday is a better time. I just, maybe show of hands. Afternoon, Monday afternoon, better.
I don't think we know at this point in time what our schedule is going to be. It makes it very hard to plan.
Yeah. Understood, Bill. But I'll take my chances on a Monday, the second week in January.
Sounds reasonable.
Yeah. All right. So we'll try to schedule for 1 o'clock on January 11th. And thank you, Alan. And thank you, Sonia, for both of you helping us. Again, I think what we'll do for the participants who are listening in and perhaps have questions. You've heard the conversation and some of the homework assignments that we have. Feel free to email me my legislative email, and we'll try to gather your questions for the next meeting. And then we can talk, Sonia, offline about just how we might admit participants for Q&A or comments that they may have on our conversation at the end of our meetings, save 15 minutes or so at the conclusion. Sound good?
Yep.
Okay. Thank you all. Happy holidays, and thanks for making yourselves available.
Senator, I think you need to do a roll call to adjourn.
We need to adjourn with a roll call. Okay, motion to adjourn, please. Yes, Gary makes it. Bill seconds. Okay, all in favor. Con votes yes. Marsh?
Yes.
Representative Woods?
Yes.
Jane?
Yes.
Tyler?
Yes.
Mary? Laurie?
Yes.
Joan?
Yes.
Kim?
Yes.
Rachel?
Yes.
Scott?
Yes.
Sabrina?
Yes.
Patrick?
Yes.
Ken?
Yes.
And Bill, at least we've got great practice with everybody's names. Again, happy holidays, and thank you for your participation and accepting your commission on this work. Bye-bye.
Senator.
Thank you.